Good afternoon, everyone. Welcome to the January 23rd meeting of the Non-Controlled Prescription Drugs Workgroup. This is an additional technical discussion where we're going to start where we left off on the January 13th call, and this is one of two meetings that we're going to have today. We're very excited to see a lot of people join today's call and register, so we have quite a bit more to cover. We are not going to take a formal roll call. Please include your name if you can, and your organization alongside your name. There's 3 dots at the top right corner of your name, and you should be able to rename yourself that way. As a reminder, the meeting is being recorded, and so any discussion that is not captured in the Excel file that we're going to be working on today, we'll be able to go back and listen to the recording and fill in any gaps that are missing. Here's today's agenda. And then before we keep moving on, David, is there anything that you'd like to share with the group, any opening remarks?
Other than to thank everyone for taking time away from their very busy schedule to help us out here. This is a very important cause, and we recognize it's a commitment of time and one that will help us shape as we move forward with the technical vendor work. So thank you all, and Anna, I'll hand it back to you.
Thank you. All right, so as a reminder for the group, we're going to review a set of potential variables that could be reported for each dispense, and we have a series of questions we'd like to pose to the work group. For our dispensers on the call, what are the technical or policy considerations for reporting a specific variable? For all of our providers on the call, which fields provide the most utility in clinical decision-making? And for the whole work group, what fields are essential for public health analysis or evaluation purposes? Now, the fields that are going to show up in a minute, as a reminder, these are loosely based on the ASAP and NCPDP standards. The fields that are shaded in gray represent fields that are in both standards. They may be called something slightly different, but they're similar fields in both standards. And we're going to try something new. We're going to have Kelly document for us today. So Kelly, whenever you are ready, you can share your screen. Wonderful. Thank you, Kelly. So we left off during our last meeting, we were in the prescription information section, and we have 3 fields that we would like to discuss together today, which are the date written of the prescription, the date the prescription was filled, and the date it was sold, also known as the date of service, or when the prescription left the pharmacy. And we are interested to hear from the pharmacists on the call. What are the policy or technical considerations for reporting each of these dates for each non-CDS dispense?
This is Leanne with Scenario. It's not a valid prescription if you don't have date written, date filled. Now, date sold can be an issue if you don't have an integrated point of sale system.
Interesting. Thank you.
Because then you'd have to manually put it back in the system in the pharmacy management system to get that date. And in many cases, the date sold, if that doesn't happen, the date sold is just defaulted to date filled, even though that may not be accurate because that's the only thing they have.
How often is date filled and date sold potentially 2 different dates?
I would say quite frequently. For example, just myself, I may get, on a maintenance prescription, I may get a notice that it was filled on Tuesday, but not pick it up till Wednesday or Thursday. So the date filled would be Tuesday and the date sold would be Thursday.
And Leanne, when is it reshelved? So let's say in that scenario you just posed, if you didn't pick it up by when does it go back into it's changed in the system and then put back into stock?
That really depends on pharmacy policy. With the pharmacies I've dealt with, they can take it out, they can clean out their bins once a week, once every 2 weeks. Usually it's at minimum about a week, but it could be longer.
Okay.
This is Kathy Graff at ACDS. I would think for your purposes, the date sold would have more value because of the fact that it could have been filled and not picked up, and you would get that data. And then if it does go back into stock in a week or two, then you'd have to reverse that.
Which is generally part of the process and reporting. It is reported. They don't have to do anything generally for that, but you could have a delay
It's just for that.
in that reversal.
Yeah, and for that week or two, your data would be incorrect. You would think it was just the patient got it, but they had not.
Very important point. Thank you.
And Leanne, did I hear that date written should be available to report for every non-CDS dispense?
Yes.
That's the actual date on the prescription itself.
Hi, Bill. It's great to see you on the line. Are there any considerations for a mail order pharmacy with the difference between date filled and date sold?
No, because generally we fill it, pack it, and ship it the same day. And the only time we would reverse is if we get the package back. Like, the patient address was invalid or something like that. But, otherwise, they're the same date for us.
That's interesting. So do you know when that happens? Do you update information for like the state PD&P where the patient lives? Do you resubmit the data?
Well, if it comes back, if it comes back, we would correct the record if we're shipping it out again. But generally what we would do is we would reprocess the prescription. And so we would reverse the one that comes back and just report the new prescription.
Right. And it would keep the same prescription number. I know we talked about prescription number a good bit last time. Is that correct?
Not necessarily. No, I'd probably not.
Okay.
It wouldn't keep the same prescription number unless it's a refill.
All right. Interesting. Thank you. Hi, Rick.
Hello, just a quick question for clarification. For date filled, obviously utilizing the traditional counting of the product, I'm assuming. But in the case of a central fill, sometimes we utilized filled as when it was adjudicated. Are we for date filled, are we strictly the definition is going to be when it was counted, i.e. I could process it on Tuesday, send it to central fill for fulfillment on Wednesday, and it could be sold on Friday to the customer. So where would is definition of filled meaning fulfillment or I'll say adjudication?
That's an interesting question. Kevin, I don't know in Nebraska if y'all, or Kathy.
Yeah, I was just going to say that when the process of filling a prescription, you need to do the adjudication, even in a retail environment.
Yeah, and this is Kevin. I think the ASAP standard was clarified the last version, but it's meant to be essentially when the label prints, when
Okay.
you're preparing, when you're affixing the label on, printing it out. That's what date filled is meant by. Another thing to consider regarding dates sold, and some of the vendors or chains can correct me, but some pharmacies will only report after that prescription has been sold to the patient and not necessarily when it was filled.
Yeah, and I would invite Dr. Morheim for his thoughts here as well, because
Yeah, thank you, David. I was about to jump in. Yeah, from an end user clinical emergency medicine family, emergency medicine perspective, you want to know when the patient picked it up and walked out with it. That's we don't really care about all that other stuff, because that's how we often, have to go back and then count the pills to see what they've taken and how many they should have taken or didn't take, that kind of thing. So we want to know when the patient or whoever picked up the medicine walked out of the pharmacy with it in hand.
Good, thank you.
I think it should be noted that for every state, date written and date filled are required fields, but date sold is not required in many states.
It's for the PDMP that
For
you're
the
speaking in.
PDMP. Yes, for the PDMP.
Right. This is Sarah from the Maryland PDMP. That trend is changing, and a lot of PDMPs nationally are starting to require dates sold, including us. In fact, we've just posted regulations with that change for comment. Because of that reason, folks want to know when the patient left the pharmacy with a prescription. And that's the feedback we've gotten that prompted the change to make this a required field.
Yeah, I can tell you that we have a best practice reports set up, and date sold is something that we always report. Whether the state uses that data or which data they use when they display the information is up to them, but we report both dates, and as I said, they're always the same for us.
Thank you all. This is really helpful feedback to hear. So it sounds like I'm not hearing any concerns with submitting date written. If date filled is something that is of interest, it should be clarified exactly what that means, but date sold would be the most helpful to have potentially in a clinical view, knowing when the patient received the prescription itself. Thank you all for that feedback. I think we can move on to our next set of metrics, which is about the refill status of a prescription. Thank you, Kelly. So we have several fields that are related to the refill or partial fill status. The first one being refills authorized, and then another one being fill number or dispensing status. If you're thinking about the ASAP standard and where these are in the ASAP standard, they're going to be moved around a little bit. I tried to group them together so it was easier for us to talk about fields that are related to each other. So I would love to hear from the pharmacists on the call. Are there any considerations with reporting refills authorized as well as fill number or the dispensing status? So this is if it's a refill 1 to 99, however many refills are authorized for that prescription.
Anna, this is Kevin. Currently, you don't have to worry about it with controlled substances because you have up to 5 refills. With non-controlled substances, we've seen refills up to and over 1,000. So in the next ASAP version, it's been requested to increase the refills authorized number of refills and that to a 4-digit number. So that's something to keep in mind.
Additionally, some of the other issues with the way the refills are done, say a prescriber says it's a prescription, it's a 90-day supply and there's 3 refills, so it's basically a year. But they start doing partial fills and they give me 30 pills here, give me 10 pills here, or whatever it happens to be, particularly when you're in a nursing home environment or a long-term care facility. doesn't. I know on controlled substances, people have gotten in trouble for saying, okay, there's 2 refills and you filled it 4 times. And so the number is wrong. And the logic is, you know, you've overfilled, not really looking at quantity. So it's really more about quantity and refills.
Thank you, Leanne. So is that specific to administration of medications, or could that potentially happen with dispenses as well?
It could just happen with straight dispenses as well, to where I'm getting my fills, even though it was written for 3 refills on a 90-day supply, I could be getting it every 30 days because that's how my insurance allows it. They don't allow a 90-day supply at retail or something like that. So you end up getting like 30-day partial fills instead of 90-day full fills.
And how is that handled within the pharmacy systems? I mean, how would it look in your example where it was a 90-day supply with 3 refills, and it's in essence being dispensed as a 30-day supply? Do we want to look at partial fills, or how would that be calculated in this situation?
It just depends on how it was entered in the system or if it was changed. It's more like that's when it becomes more about 30-day or 90-day supply with 3 refills is, a quantity of so many. And you make sure it isn't that you're violating the refills, you just can't violate the prescribed quantity. And that's where you get down into the fields of quantity prescribed and quantity intended to be prescribed.
So this is on the non-controlled substance situation, and we'd want to give some guidance there on how that should be reported. What you're suggesting?
Not really. I'm just saying that the way the fill and the refills are structured, it may be misleading as long as you're not dispensing more than the prescribed quantity.
Yeah, I think the way the standard works for ASAP, and you can correct me if I'm wrong, but if I'm doing a partial fill and it's per 90 and I'm dispensing 30 and this is the first fill, then my refill number would be, refills authorized would be whatever that is. My fill number would be 0, and then in the partial fill, it would indicate it would be 1. And then if they get another 30, the refill number would still be 0, but the partial fill indicator would be 2. And then the third one would be 3. So I've done the 90 from the original prescription. And if there's another refill, then it would be refill number 1, and the partial fill indicator would be 1, 2, and 3. So if they're getting them 30 at a time. I don't know how that's displayed on a PMP, or how partial fills are indicated.
I don't say, this is Sarah from the PDMP. I don't think that's within the clinical portal. I don't think partial fills are there. We summarize the drug information, I think day supply, the prescriber information and the dispenser information. So there are some fields that we collect with ASAP that we don't display in the clinical view. So I don't think this is one of them. Because really the information that the clinician needs is what drug was dispensed and how many, not whether it was a partial fill or not.
So I think we should note this and then move on, but I'd be curious to know from Dr. Morheim or Dr. McCree, the value of partial filled information.
From my point of view, we appreciate any shred of information we can get. but I don't want to sacrifice the good for the perfect. So whatever we can, from the ER perspective, anything we get for physicians who are prescribing for their own patient, I'm usually looking at prescriptions that another provider has written the prescription. But if you're taking care of your own patient, you have a much better idea of all these things.
So I'll add to that. I was nodding my head, agreeing with Dan or Dr. Moran previously. And also, so I'm taking care of a long-term, like let's say a cancer patient. When you miss the refill, right? There's always something else in that could impact their adherence to medications. So when I think when we're looking at technology that's going to provide a certain amount of information, although I agree that, perfect cannot be the enemy of good enough, but if there is attention paid to the fact that the prescriber can get information about, because I always have to know when I write a prescription, if the insurance company is going to allow me to write for 30 days, or if I have to keep rewriting a prescription or write a prescription to refill in 30 days. But there's a gap when the patient doesn't pick up the medication, and it does lead to adherence. And in cancer treatment, it's kind of critical that the patient is as adherent as possible. So more information is better than less information. I agree with Dr. Moore.
Thank you all. So from what I'm hearing from the group, it sounds like it's important to know what the information for the medication the patient picked up. So they know what medicine, it may be different than what was prescribed based on they can't collect all the medication because their insurance may not cover a certain day supply or a certain quantity. So it's important to see in the clinical view what the patient picked up. Is that what I'm hearing, Dr.
Yeah,
McCree?
absolutely. And
I think so.
and the other
Yes.
thing that I got to tell you, it was a big shock to me. So I'm focused. I'm probably spending too much energy on this, but it was just a big shock to me to know that what I write is not necessarily what the patient's going to get, because it depends on what NDC is available at that pharmacy. So the pharmacy gives the equivalent, I mean, not necessarily a generic, right? But gives the patient an equivalent. And it could be a different drug than it's the same drug, but it's different name. Because I always thought Tylenol number 3 was just Tylenol number 3, or Percocet just Percocet. I didn't know that there were like 10 different preparations that were the same thing that my patient was getting. And some of those do have Medi-Cal, for example, does have a restriction on certain drugs. And so if the pharmacist or the dispenser and the prescriber are kind of in sync to make sure that the patient doesn't either not get the drug or gets, it isn't filled the way that I'm expecting it to be filled. Does that make sense, Anna?
Yes, thank you. And Sharon, I see you have a comment about partial fills.
Hi, Anna. Yeah, I just dialed in, so apologize if I missed some previous conversation. So this is similar, I know we were on a call on Friday with North Carolina, and we've had a long discussion around fill numbers and quantities there. I think and I heard somebody else mention like the tracking of fill numbers and basically keeping to, right? That it's still the fill number 0 based on the prescribed quantity, but based on the dispensed quantity, it's an incremental number. I caution the group to not go down that path. A lot of pharmacy systems may not be tracking fill numbers that way. It is one of the reasons why on the NCPDP side, we've never incorporated a different value to track that way, because it's just way too complicated. And to really focus in on what the actual dispensed quantity was, the day's supply, and if you want the fill number on there, I mean, the fill number just tells you how many times that particular RX number was filled.
I totally agree with what you're saying there. This is Jason Fender from Change Healthcare. It's a pharmacy practice management system. Yes. It would be very complex to maintain that.
Every time it's
Thank you.
filled, the system would be getting a report of that. The non-controlled drug system would be getting a report of that. So you could see by looking at that patient's profile how often it had been filled. Because you're going to get a record, if you will, every time it's filled.
Yeah, the focus would be the patient, the drug, right? And the days, the date, the fill date or the receive date, and the quantity and days supply. The fill number was really created for pharmacy and payer systems. And not really from a clinical perspective.
Yeah, it comes down to making the distinction between what is a refill and what is a fill. They are two different things.
Right. And as far as partial fill use cases go, you talked about the one where they prescribe 90, they're getting 30. But there's also the scenario where pharmacy doesn't have enough, and they're going to temporarily give them 5 tablets until they get their order in. And if the pharmacy system is capable of tracking that 5 tablets being given to the patient, and then 2 days later they get the balance, how do we want that reported, that scenario as well? So there's having clear definitions of if we're going to keep these things as being reportable, what all the use cases are, the scenarios, and what is the expected outcome for each one will need to be clearly communicated.
And this is Kevin. Some PDMP states actually require partial fill to dedupe their prescriptions when they're looking at duplicate records, because you might have the same, what appears to be record come in, and if they don't use partial fill, they may actually overwrite a partial fill prescription and remove the first part. So then you lose that tracking. Not all states do it. I think it's a minority actually do use partial fill, but it does have some use in helping to prevent the wrong prescription being entered in the system.
Yeah, and that's actually a great point. So if there is consideration to leverage a partial fill indicator, there needs to be a clear definition of what we mean by partial. Because I would interpret that situation, it was strictly an inventories shortage, partial fill.
Thank you all. So it sounds like clear definitions for each, if they're going to be fields that we would hope to receive reported, and knowing that refills and partial fills may be more or less likely to happen with non-controlled. It's something to make sure that we clearly define. So thank you all for your input. I think we're going to move to product ID and product ID qualifier. Thank you, Kelly. So we heard a little bit about this in this previous conversation about the NDC code, but are there any concerns with reporting product ID and product ID qualifier for each non-CDS dispense?
It's something the pharmacy system has to track, so the only thing might be in compounds, where the issue becomes can't think of the term, real ingredient versus like a mixer. Mm-hmm. And whether you want that stuff reported.
Or whether it depends on the format here, right? So working with North Carolina, right, they only have one line for the product service ID. And so what we're doing there is sending the 0, which is what we actually send on the NCPDP claim. And then within the description would be, the description of the compound itself. they're basically putting further out, looking further, whether they may expand and start supporting the product IDs for every ingredient in that compound, but it's not something they're doing out of the gate. And so in addition to, so I think for compounds, we need to decide if there's only one attribute in the Maryland layout, if you want to stick with the 0 value to align with the NCPDP claim billing standard. And then the other question I have on product ID qualifiers. So currently today, within the claim, we call it, everything gets the qualifier of NDC. And actually your qualifiers are different than what is on the NCPDP list. I don't know if those are ASAP values or not, but in the situation where you have an OTC product like diabetic testing supplies or something like that, by default, the product ID would be called an NDC. If there is a need to get the UPC for those, that needs to be clearly outlined within the requirements.
Sharon, is the reason for that because they're all built with NDC codes. These other codes are not supported today by the pharmacy, so they'd have to put that in some other field just to capture it.
Yeah, I'd have to grab it from a different database. It wouldn't be on the car database where we pull the data from.
And then you need to make the distinction of, I know you're talking about this as all drug reporting, but are you wanting drugs and supplies like the diabetic supplies, ostomy supplies, anything else like that? And if so, how do those need to be reported?
Right.
Because most of those now have UDIs, which at least at this point, the way the pharmacy systems go, they don't really have that information in the system to be able to report, since they convert virtually everything to an NCPDP defined 11-digit identifier that's called an NDC, whether it is or not.
Right. Right.
And we probably at this point should mention that there's an NPRM out for a new NCPDP claim standard version. And the length of that number may change, as well as the support for the different types of product IDs may change in, let's call it 3 to 4 years.
The standard could change, and also the NDC number format could change.
Yes.
But Anna, if you from a reference point, North Carolina, we settled on basically what is being submitted on the claim, not a digit product ID.
Because the standard, I think, has what, 40, alphanumeric 40, but it's not used that, but it will change.
Current is 19, new standard, if approved, will be 40.
Yeah, and that's 3 years down.
Kevin, have you run into any issues in Nebraska with NDC being reported consistently, or any issues with that?
We have run into some challenges with not necessarily the length, or that we do get voluntarily, some people will send diabetic supplies, for instance, like what was mentioned. What we do run into are items that are not in one of the national drug databases, whether it's FDB or Walters Clur, Medispan. So we do find it's a relatively small number, but still significant number of unknown items that we're working on with our vendor, our PDMP vendor, to create a customized NDC database, and we have to look those items up. So it might be a Walco Stop Mark Green's brand of ibuprofen that's not in there, or Depends, or something along those lines. So Most drugs are in there, but usually it's those specific store brand OTCs that are missing, and then some of those supply type items.
Yeah, and lots of times what happens with the OTC products, whether it's a store brand or if it's a store brand drug, I would expect that the drug compendia have those values, like an acetaminophen and ibuprofen, right? Versus a store brand, you know, incontinence supply or something that, you know, a non-drug item or any other non-drug item. That's where you can get some variations in the numbers, and you're probably getting the gap in the matching, because it all depends on how the pharmacy team, they couldn't find the record in their system, so they manually enter it, and they try to interpret that UPC code into an 11-digit number, and they fail.
Thanks. And Rachel, I see your comment about compound drugs and having the drug name on the label. That's something we can look into with the Maryland Board of Pharmacy. I don't believe we've run into that with the PDNP before, so I'm not sure if it's similar to a California situation, but that's a good question, and we'll look into that. Thank you.
Thank you.
All right, so far we've gone through a few different dates for the prescription, some information about fills and refills and partial fills, and then the product ID and product ID qualifier. Kind of thinking of that group of measures, I'm hearing from the group that having an accurate representation of what was picked up from the pharmacy would be helpful to see in a clinical view in CRISP or an EHR. Are there other aspects of those variables that are going to be helpful to see in the clinical view? That's okay if no one has feedback at the moment. I know that was a grouping of variables, so that's quite all right. Kind of the same question for public health considerations. Which of these fields would be helpful to collect for public health analysis or evaluation purposes?
So, and maybe I could ask that question a little differently and see if Dr. McCree could weigh in here. So you mentioned that you were a little surprised that, say, there's a brand to generic, even though they're the same, and that, can you elaborate? Is it that even though they're the same, they're not? Is there a concern that the impact on care delivery could be different? Is there the impact on outcomes? I'd be curious to know your thoughts. When oftentimes the non-clinicians, I think about this in terms of cost, whereas from a payer's perspective, it's cheaper to use generics and not anything. There are no other differences, but my assumptions here could be miles off. Your thoughts?
Right. Thank you, David. No, all I was saying was that we as prescribers do not know all the different choices when we write for a specific drug, right? Because some drugs have a lot of, you know, they could have many names, right? Like oxycodone, for example, is, and I know this is a non-CDS call, but, you know, even medications medications that have more than two components, more than two or more drugs in them, like Tylenol with something else, right? Like our patients don't always know that Tylenol and acetaminophen are the same thing. So then they'll go out and get something else with also has acetaminophen in it. And as you know, that could be a considerable concern if that person is also taking, you know, an antibiotic and, you know, drinks wine every night or on oral contraceptives, you know, so there's multiple liver insults that you can have at the same time. And now if they're taking more than one dose of Tylenol in a combination, in multiple or more than one combination drug, it's just easier for them and, you know, for the clinician to know which drug they're picking up, so that, and how it's labeled on the, or how would the patient know that they're getting acetaminophen in multiple preparations. I mean, I do my best to make sure that they know both over-the-counter and prescription medications, but that would be, I think, the biggest thing for me. And it was just a surprise to me that NDC, that, you know, that multiple or the same preparation can have multiple NDCs depending on, you know, the labeler or the place of dispense and stuff like that.
Got it. Thank you.
And I do, and to answer, to comment a little bit on what Rachel said, and maybe I'm not reading the question correctly, but for compound, this is again, you know, for compounded drugs, we do want to know what the component parts are. So it might not be relevant to the to maybe the dispenser, but the prescriber needs to know what is you know, what was compounded into the drug that, you know, I mean, typically we like I just know that we did some capping studies in pregnancy. Well, you know, when I was in practice, and they and we had to compound the drug in a special pharmacy and then distribute it to the patients. But if there are other compounded drugs, we would like to know what's in them.
David, public health considerations, I think, in this area could be vast, but probably I think it's something we should worry about later. For example, you could decide, public health consideration might be, you know, different prescribing patterns. It might be payer mix. Are they getting their hypertensive medicines, or by geography? Are they picking them up in time and taking them? I mean, there's all kinds of public health implications. You may be able to identify different kinds of side effects and complications if there was a big database on it. But I think the first thing, you know, sort of, at least my mind, you know, is able to think of a lot of public health implications about how pharmaceuticals are prescribed, dispensed, and taken. But for now, I think the first thing is to focus on getting the basic information that we've outlined.
Yeah, no doubt. Thank you, Doctor.
This is Kevin. From a clinical perspective, we don't see it a lot, but it does happen where the providers may write for dispense as written, or with all the new biosimilars coming out and generics, provider may specifically want a specific product, and knowing the brand trade name of the dispensed product can be valuable in those cases where maybe there's an allergy to an ingredient in a product, and the provider specifically wants that one avoided, for instance, and they write for something. So we do see that in Nebraska occasionally. That's been a request.
And following up on Kevin's comment, it is critical that you actually have the NDC number of the drug, because looking at, let's say, all the acetaminophen, well, maybe somebody has an allergy or an adverse effect to either the coloring or the coating on the pill. It's not to the drug itself, but it's something in it.
I'm not sure if it would help, Anna, but I keep referring to the North Carolina format. So in that format, we're sending both the product ID, so let's say the NDC in this situation, in product label description.
Thank you. Sarah and Maya, can you remind the group, so it's not a product ID or a product ID qualifier that's displayed in a clinical view, but the information is matched in an additional data set, is that correct?
Yeah, and in this particular field, the product ID qualifier, you guys were talking about compounds earlier. So if it is a compound, you would designate that by 06, and then there's a whole section, again, this is based on ASAP standards, that you put more information in regarding the compound. So in the PDMP, that is collected in a separate, the compound information is collected in a different section. And Anna, to address your question directly, what we do is we have a medication database called Medispan, and that matches that NDC number with specific drug information that we append to the dispense.
And that's what's displayed.
And that's what's displayed in the clinical view. Yeah, perfect. Yeah.
Thank you, Sarah.
Mm-hmm.
Well, thank you everyone for feedback on these set of metrics. I think we're going to move on to the next three are going to be quantity dispensed, drug dosage units, as well as day supply. So it may be helpful to think about quantity dispensed and the drug dosage units as together, and then day supply as another metric. But are there any concerns with reporting all three of these for each non-CDS dispense?
And that just be part of the prescription is filled?
Yeah, the only
That's a
thing
good
that
question.
you, I was just going to say, and this kind of goes back to the number of refills, whether it's a PRN or whether it's a solid day supply.
Yeah, I think we're going to get to the RX SIG, which is the instructions on the label soon. That's one of the fields we do want to talk through. But before we get there, is there any concern with specifically reporting the unit code, like whether it's milligrams or milliliters, in addition to the dosage?
So, Anna, the only thing you may want to be concerned about is the terminology used here, and maybe within the description, it can be, blown out a little bit more, because sometimes your units from a dose perspective are different than the unit of measure of the product. I mean, and that could occur with injectables.
I think I'm following you. Okay.
Yeah, your unit of measure of the injectable could be milliliters, right? Because it's a liquid, right? But your dose is a microgram or a milligram or something. So we need to clarify what you're looking for. Are you looking for the unit of measure of the quantity that was dispensed? So it was 0.5 milliliters. The unit was milliliters.
So I think these fields are specific to the quantity dispensed, and then the information about how to take the medication would be something that would be covered in like an RX SIG field, which would be more of the description of how to take the medication. For others who are more familiar with the ASAP standard, is that your understanding of the differences between the quantity dispensed and how it's taken?
That's the way we've always interpreted it. Is we're reporting the metric quantity of the medication that we dispensed. And so I guess the 01 used to report solid dosage units or individual packages. For instance, let's just say a nose spray comes in a bottle. So that's an indivisible package. But the package is 14 grams. And so we report 14 because that's the metric quantity that's being dispensed. And we use 03 for grams, not 01 and 1.
Understood. Thank you, Bill.
I mean, typically your drug compendia vendors will have a unit of measure associated to the product. Because it is definitely something that needs to be standardized. Like, are you talking about the grams, or are you talking about the number of inhalers, or, some of those, inhalers, injectables, anything that's not an oral solid can get very confusing on what the unit of measure is.
And Sharon, are you saying that's standardized by like NDC or?
Yes, the products should be, NCPDB has guidance on what those units are supposed to be. If it's a kit, if it's, some like those products that can be confusing.
Thank you.
That's why the field name to me is a little confusing here, drug dosage units code. Because you don't have, because it's specific to each milliliters and grams, I would correlate this to be the same as unit of measure.
Thank you. Are there others with feedback on day supply? And just to confirm, based on our earlier conversation, this is the day supply dispensed, not necessarily the day supply prescribed. That's how others have been using this field if they're using ASAP.
Well, again, you have to look at it as if they're getting it as needed, that day's supply may not be accurate. Let's say like it's a cream, a corticotazole, it's cream for something that they may or may not use every day. That's the only concern you probably need to look at, is it may not be accurate on certain types of medications.
Well, it's an estimate, right? We don't know what it's.
They make a guess and they come get it again when they run out.
That's helpful. All right. And I'm sure I can think of, 10 ideas off the top of my head for public health considerations with these fields, similar to what you're saying earlier, Dr. Moore. I think there's quite a bit that could be used for this. So they are important attributes of the medication dispense that's important to collect. And then similar, for those who would be viewing this information in a clinical view, it's helpful to have both the day supply and the quantity dispense displayed. Is that correct? I believe these are currently both displayed in the PDMP. Sarah or Maya, you can correct me if I'm wrong.
Yes. Day supply, and what was the second one?
The quantity.
Yes. They are both displayed in the PDMP.
Yeah, generally I'd say make it as similar to the PDMP information as possible, since we get used to looking at that. We'd like it to be in the same format, so you're not, as a clinician, looking at different formats or in different places.
Thank you, Dr. Mohan. Our next field is the transmission form of the prescription of origin code. This is a newer field, I believe, in ASAP, and I would be really interested to hear from the pharmacists on the line. Is this something that could be reported consistently for each non-CDS fill, especially as more prescriptions are moving to e-prescriptions? Kevin, did you have something you wanted to add here?
Yeah, we do capture the transmission type. It's very consistent. We get almost 100, well, I'd say we get 99+% of all prescriptions with some type. When we look at all prescriptions, controlled and non-controlled, we have about 68% that are e-prescribed. In Nebraska, we have about 79 to 80% of controlled substances that are e-prescribed. So we capture it in whatever form it is.
And I think this is a field that has value, but it's less on the clinical aspect. Dr. Morheim, your thoughts there?
I don't think it matters that much from my point of view, but I'd probably want to think about that and maybe talk to some other clinicians.
How about Dr. McCree? Your thoughts? I feel like in the end, as long as it's delivered, taken, and managed, you're less concerned about, is it electronic or fax? I mean, there's efficiencies and administrative elements, but from the care delivery, it doesn't strike me as what you would view as significant.
Mhm.
You're right, David. That's it.
Yeah. Okay. Perfect.
I do see we have Dr. McGarvey on the line. Dr. McGarvey, is this something from pharmacy owners that reported consistently?
Yeah, it's pretty straightforward. That's why I've kind of just let the other folks, they've been spot on. Not a hugely significant field. We see it mostly in the audit realm. Like if a third party wants to say, hey, you've said that this is a phone in, when in actuality, it's an electronic transmission. And so we've seen some movement in there, but clinically, it's not that relevant. And it's been longstanding and easily conveyed.
Thank you.
Thanks.
I would concur with the PDMP. We use it really as kind of an auditing function. If we get a call from a prescriber, like I didn't write that prescription, so then we go back, and if we find it's electronically submitted and we can figure out. So it's really used for auditing and data compliance and correction. It's not displayed.
Good point. Thanks, Sarah.
But on public health considerations, it could be used as to which side has the technology to accept both. Like, for example, there's a prescriber, particularly a specialty type prescriber, who doesn't have the ability to do so, or a specialty type pharmacy that doesn't have to, but given all the regulations, that's going away.
Yeah, no, that's a good point.
Electronic prescribing.
Yeah, there
is
is
mandated.
Yeah, there is a piece about the health equity side of this that I think from a public health, you can look at it. So there are many ways you can go about taking a look at how this data impacts the different regions, populations, demographics. So it does have value, but certainly not so much from, as I think Sarah mentioned, from the displaying and some of the physicians noted about in terms of its actual treatment utility.
Thank you all. In previous calls, we've had pretty thorough conversations about the reporting of pharmacy versus pharmacist in PI. So, and same with the state license number for the pharmacy. So I'm going to skip over these two measures and move us on to the payment type. So for our pharmacists on the call, could the payment type for each non-CDS dispense be reported consistently? And these are the options that are available in ASAP. I know that this is something that's quite differently reported in NCPDP.
From Nebraska's perspective, it is reported pretty routinely. We do run into some challenges with some specialty pharmacies or compounding pharmacies, depending on their software, that don't have it properly coded. The accuracy too could come into question on if maybe that prescription was initially run through as commercial or Medicare, and then when the patient is there, they may change it to private pay or Medicaid or something else, or maybe workers' comp. So I don't rely on the accuracy of the payment type all the time. It gives a great understanding overall, but individual scripts may have to be scrutinized at times.
And again, I'll go back to, this is kind of like the date sold. If it is not, if the point of sale system is not integrated with the pharmacy system, what came out of the pharmacy system may be changed at point of sale, and so it would be inaccurate. Like they thought that they were going to pay cash, and they came in and they had insurance or, you know, workers' comp, that kind of thing. It may never have been changed for the pharmacy system and rerun.
So, Dr. Porcher, on the private pay side, is there reporting back to you to the non-CDS, or is it, how is that, are you receiving that information? Is it being pushed from like a Walgreens or CVS to you all as well? Or is that a field, if it says 01, it's not being reported, or 99?
No, we're getting private pay routinely. It's probably, we do get some listed as 99 or other. About 5% of our scripts are listed as that. But I would say we do get that fairly routinely. Another challenge is, let's say it's a home infusion, home health pharmacy that may have a separate billing system that doesn't use NCPDP for adjudication of claims. They may have it all run through their medical billing, for instance. And so the accuracy may not be there, and they may put in other compared to what maybe it really is.
Okay, got it. Thank you.
This is Sharon from CBS, and I can tell you today, the accuracy of these values is pretty low, right? The only one that you can probably really count on is your Medicare one, because the distinct identifiers that are used within that claim adjudication process. So what happens on the pharmacy side, at least this is what happens on CVS. I don't know how other pharmacy systems do it, right? We have internal plan codes, right? So Sharon Greta is getting, you know, she has insurance with the Caremark commercial plan, right? Through my Aetna insurance. And there's a plan code that's associated to my profile, and that plan code is categorized as a commercial plan. And so that's what we would send to the PDMP, right? That it was a commercial plan code, but it's a guess, right? Because we don't, once that claim is sent to the payer, we don't really know if it's a commercial benefit. It could be a Medicare, you know, supplemental plan. It could be some type of a Medicaid plan. It could be a Medicaid exchange plan, right? We don't have visibility to those specific details.
And Rebecca, is that the same for Walgreens? And you may be on mute or stepped away.
For Wise, it would be very similar. Sorry, I know you called out Walgreens, but I think that's a general case. If it's a Medicare, it's a little bit easier to know. But you can utilize like Medicare Part D underneath the commercial insurance plans, and typically those claims will go through. So your Medicare information is probably a little bit cleaner, and the commercial insurance is probably a little dirty, meaning that it could include both Medicare Part D or Medicare or commercial, all in that same bucket, as well as your payment code of 05 could include like or your 04 could include like TRICARE for military personnel as well. So if you're trying to get to that, just so you're aware of that.
Yes.
Yeah, so like, there's nothing that really tells a pharmacy provider. I mean, years ago, it used to be you looked at an ID card and you could try to figure it out. Today's world, it's all electronic, right? And the eligibility, and it's all based on what we call BIN and PCN numbers and where the claim is being routed to, right, for us to figure it out. But good news is that this new version of the NCPDP claim billing standard that we said is coming that's under the NPRM, there is a new attribute that was added to that. That on the claim response, the payer has to tell us, well, what type of program did you pay the claim under? Was it a commercial benefit? Was it a Medicare Advantage? Was it a PDP? Was it a, you know, a Medicaid exchange plan? You know, what was it, right? And so that's when you'll see the pharmacy providers shift and use that attribute to report to the state what the plan type was. But that's a few years down the road.
Yeah, I think from a public health utility standpoint, the validity of this field or the reliability of it in any way is probably marginal at best.
Mhm.
And Sharon, you have to remember in the next standard, there's what, about 30 or 40 or 50 different program types. So this only has 8.
Yeah, good point, Leanne, because like, that's what I would like to bring in. I would like to use the same list, right? So they know what we're talking about, so that the pharmacy doesn't have to consolidate the NCPDP codes into one of these, because now you have a guessing game.
Yeah. And even with the payer response, does it always get integrated back to the billing system? And why, if you're using the routing number off the prescription drug card, is it even necessary?
Can you repeat that? I'm sorry.
Well, at this point, that field is not being returned by the payer and won't be for probably a minimum of 2 to 4 years.
Yeah.
And at that point, they'll determine how accurate it is.
Right, okay, that's what I'm thinking. Okay, that's helpful.
Yeah, well, the payer's classification is a lot more accurate than the pharmacy's.
That's right. Good input, thank you.
Thank you. And we have segments later on that are specific to NCPDP format about insurance claims and pricing. So we will be able to talk about that a little bit more once we get there for different field options. But the next 3 fields I'm hoping we can cover are all specific to e-prescriptions. So that's the RX norm product qualifier, the RX norm code, the e-prescription reference number, and the order number. So these are only applicable for e-prescriptions, I realize, but are there any concerns with reporting this for e-prescriptions?
Well,
Some systems don't have the RX. Some pharmacy systems do not have the RX norm system implemented. So yes, that would be a problem.
and what are you looking for row number 123, electronic prescription reference number?
I believe this is one of the newer variables in ASAP. Kevin, I don't know if you could speak a little bit to some of the background on some of these RX norm and e-prescription fields.
Well, the RX norm I get, it's, and Leanne, maybe you have some information on it. Is that the name of the script field, the electronic prescription reference number?
Yes, it is. And I'll defer to Kevin on the latest conversations at ASAP about those, but it's the tracking numbers that are used to monitor the transaction and link them up between a prescriber and a dispenser.
Wondering from a HIE or PDMP perspective, why that level of detail is needed.
Yeah, I was just going to say, I would think, why don't we start from the clinical perspective? And I think, you know, if I were guessing, but we can get a confirmation from our physicians, probably not much use at all. Dr. Morheim, Dr. McCree, your thoughts?
Agree.
Yeah. And I would almost assert that from a public health utility standpoint, not much value unless somebody wants to tell me I'm wrong. I definitely think it has a tracking mechanism for administrative capabilities.
Or an auditing.
Or auditing, yes. But from the clinical health utility and decision-making, probably not all that valuable.
And I mean, the rest of the information regarding that prescription that's being reported here, the pharmacy can go back and find that, right? It's going to be their internal tracking.
Yeah, I agree.
Okay, great. I think we can move on then to the RX sig field. So this is something we talked about before. I believe this is an ASAP variable, and this is the actual instructions on how to take the medication that's printed on the prescription label. I've heard from some earlier on when we were initially collecting feedback that there may be an issue if the field is particularly very large, maybe even more than 200 characters. But I'm interested to hear from the other pharmacists on the call. Is there any concern with reporting this information?
This is Kevin again. We do collect it voluntarily. About 60% of our scripts do have it, which isn't bad for being a voluntarily requested field. The challenge is the quality of the data being reported, that some might report take 1 tablet by mouth 2 times a day. Others might say 1 tab, PO, BID. Others have their SIG codes in there from their pharmacy, 1 QD, BID. So the quality isn't there. Whether you can try to map that or create a crosswalk. Most of the data I would say is good, but there is a fair number that's not qualitatively helpful.
Yeah, Kevin, I was just gonna, call that out. I mean, do you send the codified SIG when you have a codified SIG? I mean, codified SIG isn't used across the board today. You get so many variations with scripts. It's difficult to use a codified SIG. That's one of the reasons why it hasn't moved forward from an NCPDP perspective. And then if you do the actual, text version of a SIG, you may lose if it's truncated at 200 characters, you may lose the bulk or the body of the instructions. On the NCPDP script standard side, this field is expanding to 1,000 characters in their next version.
Actually, it's already 1,000, is it not?
But it was this next version.
No, actually, the
2017-071
The date.
is 1,000.
Oh, is it? Okay.
The SIG code and the diagnosis code are the 2 top requested enhancements that our providers have asked for, because it does help. If you get it, it may be able to assist you from a clinical decision-making perspective of what did another prescriber write this for QID or QID PRN. It may help for nursing facilities as you're doing med rec and understanding some of that. So even though it's not great data, it's something that the providers do find value in. They just wish it was more valuable.
Yeah, and I guess that's a good question to pose to Dr. McCree or Dr. Morheim. I think Dr. Borcher mentioned it very well. Would you concur, or do you have a difference of viewpoint?
I got distracted at that point, so if you could just repeat it quickly.
Yeah. Do you find the free text characters for the RX SIG file useful? Which is the directions printed on the prescription label.
It's helpful, yes.
Kevin, can I ask you a question? Because I'm not a Nebraska pharmacist. I've never seen the Nebraska PDMP. I know that you collect the directions. Do you actually display them on the PDMP?
We do. That you have to drill down to see them, and we're working on an enhancement to make it more like a hover, so it's easier and quicker to see. But we do display that and the ICD-10 code if it is collected.
Okay.
It's helpful, but not essential. I'll give you an example, like treating a urinary tract infection with antibiotics. Sometimes it's recommended people take them all at once, or some doctors recommend taking them on a, BID or TID. So it's helpful to know, but, get by without it.
Yeah, and Sarah, have you heard any feedback on the other side of the house, if you will, on the PDMP to this field value?
I think Sarah may have had to jump, but if Maya is on the call from Chris.
Well, maybe Anna, you can talk from your past experience.
Again, these are two fields similar to Kevin. When I was with the PDMP that were requested quite frequently, there's always the concern of how to fit this information into either an integrated EHR or to the CRISP interface. But we have heard that it's incredibly helpful to know what instructions the patient's getting and how they're taking the medication, if that's any different than what the prescriber had intended, for instance.
Understood. Well, that's helpful to know.
Because the SIG the SIG is one thing, the pharmacy always has that. The diagnosis code is the one that is extremely problematic. If the prescriber does not include it on the prescription, pharmacy can't generate that. And not only that can't they generate it, but the only way you're ever going to get diagnosis code is if a state would mandate it that it be on a prescription. And what becomes even more problematic about it is the way some of the EMR systems and EHR systems work, is that they use SNOMED code.
Right.
And the ICD-10 code is more of a billing code. So that at the time the prescription is generated out of the prescriber's system, that billing code may not be on the prescription at that time.
That's right.
The problem that we run into is that the diagnosis that comes on the electronic prescription, and that's where we almost always see them, may or may not relate to the medication that's actually being prescribed. And, the patient's main diagnosis might be hypertension, and they broke their foot, and so they got a prescription for a narcotic, but it's not related to the hypertension. But they don't change the diagnosis code in their software, so we get hypertension and a prescription for Norco.
It's not reporting secondary and tertiary ICD codes.
Well, it's more or less, it's dumping what's ever on the diagnosis codes into an electronic script, whether it's related to the prescription or not, despite the best guidance, the best practices guidance. Now, in the next version of the script standard, which is also under NPRM right now, they have made changes that could come in handy in future versions, to where there's two different places for diagnoses, which is one, just general ones related to the patient, like hypertension or high cholesterol. And then there's a space for the diagnosis directly related to the prescription that's being written. But that, again, is probably 3 years away.
Well, let me share a little dark secret here. Anybody that believes that ICD-10 codes are accurate to what the patient has is living in a naive world. If you don't have any sense of it, go pull down an ICD-10 code and try and think of a couple of common diagnoses: gastroenteritis or stomach upset, whatever you want to call it, or sprained ankle. I mean, there's dozens of choices, and I forget how many tens of thousands of ICD-10 codes there are. Yeah. You could have people with identical situations, or getting somewhat different ICD-10 codes. And so, when I was being an ER doctor, I'm just trying to finish the damn chart so I can get the patient discharged, and I'm looking at ICD-10 codes and picking the one that seems most immediately relevant, but it may not have been the most possibly accurate. So that's just real world.
But then I also burned while water ski is on fire, so which is an actual ICD-10 code.
Also, hit by falling spacecraft is another. But I mean, it just doesn't really hold up if people are going to be really honest about what they're choosing. They're doing the best they can, don't get me wrong, but it just doesn't really work that way.
It's hard enough getting the diagnosis codes accurate on opioid prescriptions.
Yeah,
I wanted to-
most of the EHRs actually won't let you order narco for a broken foot. It'll ask you to make a diagnosis that goes with that medication. But Dan is absolutely correct. There's 100 different diagnoses for hypertension, and it depends on whether it's essential or caused by something else or what have you. So if we're looking at some kind of technology that's going to narrow things down, I think that's what we need to do. But these ICD, we need to keep open-minded about not what we have now, but what we could have, right? And so, but it is absolutely true that this ICD code is a billing, it's for billing purposes. We can't guess. And normally what I do is I check off the previous one or the one that the previous EHR entry had, thinking, that guy, was closer or to the original diagnosis. So I just use this one, but it's really, really inaccurate.
Okay, so not much value on that, on the public health consideration aspect for now, but fingers crossed for 3 or 4 years from now.
If we could jump up to the RxSig again from the technical perspective, something very, very important that we find is that some pharmacy staff will enter the field separator, such as an asterisk within the RxSig. They do that with maybe patient name or address as well. But if you enter that asterisk, which separates fields within the ASAP format in many cases, it causes a right shift of the data, and then all of a sudden you have too many fields. Instead of 25, it might say you have 27. Now, a lot of vendors can handle that using like escape characters or other characters for that, but we do see that at times, and you'll want to be aware as you're getting data in, you may see some invalid fields go up.
Thank you, Kevin. All right, so it sounds like fields would be really helpful if the information was condensed and accurate, but we may be a little bit off, especially for ICD-10 codes. I think we can cover maybe one more set of measures before we take our break before the next meeting. We've already talked about prescriber, NPI, and DEA suffix earlier when we were initially talking about pharmacy. But just wanted to confirm with the group. Again, I don't want to assume the prescriber's first and last name, all of the name information about the prescriber writing the medication. That's something that's going to be available to consistently report from prescription to prescription, correct?
Except if those prescribers do not have a DEA number because they do not prescribe for controlled substances.
Or I'll go
Right,
back to the institutional DEA number that many of us worked under.
Well, in that instance, you would have a suffix though, right?
There is an option to submit DEA suffix, which could, I think, except for maybe in military settings, which is what we talked about before, Dr. McCree, military hospitals, but it may not be readily available, but for others, we found in Maryland that suffix helps if you're writing under an institutional DEA number.
Right. We actually check the DEA number. We get a feed every day from the DEA, and so when we get a prescription that has a DEA number, we validate it, and if it is not for a human, we require the suffix.
Interesting. Thank you.
Can I ask,
But it sounds like
how would there be any, if there's any auditing around the suffix, how would that be done? Because it's not a regulated database. The suffix is assigned by the organization. Sometimes the suffix is that individual prescriber's NPI number. So it's the hospital DEA and then the individual, the practitioner's NPI number, which is 10 digits.
I do think Sarah has jumped, but I can share in my experience when I was working with her with the PDMP, we've seen a change in how frequently DEA suffix and the information that's provided in that field has evolved over time to include more individual prescriber information. Now, it still could be that the prescriber is still writing under a different DEA number, and that happens sometimes in institutional settings, but over the past few years, that field has been used more and more in the Maryland PDMP to look at individual prescribing trends.
Yeah, I guess, Anna, and my apologies, right, because I haven't been on all these calls here, but I'm not understanding the benefit of requesting the DEA number suffix to be reported if you have the DEA number and the individual prescriber's NPI number in their own fields. You know
Yeah,
who the individual is, and you know if that individual doesn't. So if that individual has their own DEA number, it would be reported in that DEA number field. But if that individual is using an institutional DEA number, that institutional DEA number would be reported.
Yeah, I think to your point, from that aspect alone, it would provide some public health utility. But I don't know that it matters so much that we necessarily know the individual uniquely here using a suffix. Because I think what you're saying is you can get at that information another way.
Yep. You basically want to know who owns the DEA number. Is it
Right.
the individual or the institution? And then who was the practitioner that prescribed?
Right.
DEA number suffix is nothing, right? It's that institutional's way of assigning, those suffixes. It could be the person's initials, it could be their cell phone number, it could be anything, right? Each institution applies their own, and suffixes are not registered anywhere. There's no way to validate them.
What I can say is that if you've ever been audited by the DEA, if you don't have it, they have serious questions.
Oh, totally agree from the DEA, because it is a regulation from the DEA, but from a clinical reporting perspective, I'm not.
And
In bigger facilities, so it is used to differentiate between, say, at Johns Hopkins, if you have 3 Dr. William Jones, then it becomes something, if somebody needs to follow up with a prescriber, that then it helps differentiate people of common name.
Yeah.
But
But the
point's well taken.
NPI should give you that, right? The NPI.
Yes.
Yeah.
The NPI would also do that.
It's just another field to help bolster the information. But you're right, it is non-uniform by its very nature.
And I think Dr. Moorheim was going to say something.
It's further down up, it's scrolled up, but if you scroll down to the prescriber's name, first name and phone number, that's nice to have in my setting, because I will often call up a physician who's prescribed and say, you prescribed this, can you tell me why I'm thinking of switching to that because of what's going on clinically? It's for the continuity of care from, the ER perspective, since every patient we see is a one-off, but we also like patients to, follow up with their regular care providers. And sometimes now there are other ways to get that information. It's not this would not be the only way. But if it's available in there, that's convenient.
Understood. Okay. So, Anna, you want to keep us on track? We don't want to run too far over, since some of these folks will be joining us back in about a half hour.
Yeah, thank you all. And we're really happy that a lot of you have also registered for the meeting that's at 2. So we're going to take a break between now and then. I put the link in the chat for anyone who needs it for the upcoming meeting at 2. But we really are really appreciative of all of the input you've been able to share so far, and we look forward to continuing this in a little bit.
Yeah, great dialogue, everyone. Huge round of applause. Thank you.
Thank you.
Thank you.
All right. See everybody soon. Thank you.
Thank you.